Hi, welcome. We are going to start in 1 more minute. So if you want to finish up what you're doing, get your last drink and cup of coffee, then come on back to the screen. We'll be available in 1 more minute. Hi, this is Robin Axel Adams. I am the manager of the Fairbanks Center for Medical Ethics, and we are thrilled and humbled to welcome you to the inaugural lecture of the 2021 Fairbanks Lecture Series. We never knew when we invited Dr. Hartwell so many months ago how poignant this lecture would be today, and so we're just thrilled that you are joining us today and that Dr. Hartwell is with us. We are so sorry that we had to cancel our April and May lectures, and we really appreciate your rejoining us for this month. As you can see on the screen, we have some really great lectures planned for the rest of this month that are already, or the rest of this year, and are working on some more great lectures starting next year. Before we jump into the lecture, I just want to give a great nod to our Fairbanks Fellowship in Clinical Ethics, which began last week. We welcomed 6 new fellows last week who we are so glad we're able to meet in person thanks to the help of infection prevention while we are socially distancing. And so I'd like to introduce the fellows. I will only be able to do it by name. We won't be able to recognize them in person this time, but hopefully you'll meet them at some point. So I'm excited to share with you that Faraz Al-Musali, who's a doctor, and right now is a COVID case manager at Purdue and a research ethics fellow at South Carolina, is joining us. Katrina Klingerman, who is associate general counsel with IU Health. Matthew Edelman, who's a staff chaplain at Norton Audubon Hospital in Louisville, Kentucky. Ashley Johnson, who's a nurse on the transplant unit at University Hospital. Rafael Mendez, who's a certified medical interpreter at IU Health and their program coordinator. And AJ Ratford, who's a clinical risk manager at IU Health Bloomington. We're thrilled that those 6 have joined us through this year. We would like to also invite you to visit our website, fairbankscenter.org. We have just relaunched the website and redesigned it. It is beautiful. It had a major makeover, and so we hope that you will look at our website and get resources that you need. A couple more preliminaries before we let Dr. Hartwell begin, because I know you really want to hear her. We appreciate your understanding for any technical issues that may develop during this webinar. We have all learned so much in the last 6 months, but we've also learned that technology rarely works perfectly. So we apologize ahead of time if anything goes wrong, and we celebrate if nothing does. This webinar is being recorded and will be available at our website, fairbankscenter.org, within the next week. If anyone that you know, once you hear this awesome lecture and you want to share this with your friends, if they would like to receive CE credit, they can go to our website for the next 30 days and get credit. If any physicians or others, advanced practitioners, need CME credit, you'll be able to do that for a year. So we hope that you'll send out this information and people will still be able to get their CE and CME. For those of you that have signed up, you will receive a link tomorrow for your CE and CME evaluation at the email address that you used to register this webinar. If you're watching it as a group, please contact Annie Motz at KMotz, and she'll be able to send you that link. Please fill out the evaluation even if you don't need credit, because that is the main way that we are going to be able to track virtual attendance, and that also lets you have the opportunity to provide some feedback and comments on the lecture. So the Q&A box will be available to post your questions. However, we will not be responding to the questions for Dr. Hartwell until the end of her presentation. If you have questions about CE or CME, go ahead and put those in and we will be answering them, but I will be helping Dr. Hartwell with those questions at the end. And then finally, Dr. Hartwell has no relevant financial conflicts of interest to disclose. Okay, now the real purpose that you're here and the real reason. So let's get to that. Dr. Hartwell is a trauma and acute care surgeon who practices at IU Health Methodist Hospital in Indianapolis. She completed her medical school degree from Wright State University in Dayton, Ohio in 2005, followed by a General Surgical Residency at the University of Illinois at Chicago in 2010. She finished a fellowship in trauma and surgical critical care from the University of Tennessee Health Sciences Center in Memphis, Tennessee in 2011. She worked at Grant Medical Center in Columbus, Ohio, before joining the faculty at IU in 2016. In 2019, Dr. Hartwell was named an inaugural Chief Wellness Officer and Associate Dean of Wellness in a joint venture between IU Health Physicians and Indiana University School of Medicine. She collaborates with wellness leaders throughout the school and medical campus to promote a holistic approach to wellness for all learners and providers as she continues to care for critically injured patients during her clinical time. She resides in the Indianapolis suburbs with her husband of 22 years and their 4 children. So Dr. Hartwell, we welcome you, and we are so thrilled that you are available and are able to share with us your wealth of knowledge. So I will turn it over to you.
Thank you so much, Robin. I appreciate the invitation, and I'm looking forward to this talk. So let's get started. So today I was asked to talk about moral injury, burnout, compassion fatigue, and maintaining hope. And it's true, this talk would have been very different had I given it in the spring as originally planned. So I'm grateful for the opportunity to march through this time with you all and share kind of what I've learned along the way. I have no disclosures except to say that some of these topics can be a little controversial. People feel very emotionally passionate about some of these topics. And so I just want to clarify that my intention is to spark a conversation, not necessarily endorse or promote any one specific concept. And I think you'll understand what that means as we go through the talk. And I'll also disclose to you as a reminder that I am a physician, and I know many in the audience are not physicians. And so I want to be respectful of that. And I'm going to try to make sure the conversation is very holistic and really tries to take everyone's perspective, but I will remind you that I am a physician and that is my default perspective. So grab your phones and keep them handy. Find your camera app and keep it nearby on your home screen, because throughout the talk, I'm going to place some QR codes that you'll be able to hold your phone's camera up to. And then in your Explorer or your web browser, it will take you directly to the source document that I'm referencing. I have 3 or 4 of these throughout the talk. Some people enjoy going straight to the source document, so I've embedded these in the talk. I also want to point out that in this era, giving a talk over Zoom is kind of strange and weird, and I kind of feel like Tom Hanks talking to Wilson in Castaway because I don't have any feedback from you all. So I hope that I can remain engaging, and if you have any feedback for me in the Q&A box, I would love to hear that. But it's a strange time to be given a talk, so just kind of bear that in mind. All right, here are my objectives today: to talk about moral injury, burnout and wellness, compassion fatigue, and describe how all of these issues affect our work and personal lives, and then kind of give some action items that we can use to mitigate these issues and bring back some joy into our work. So if you're anything like me, which I imagine we're all kind of in the same boat these days, a lot of us working from home, splitting our time clinically and at home, we're just really fatigued. I was talking to Annie about this before we started the talk. There's just kind of this exhaustion that I think a lot of us are facing. And it's a little bit from the work that we're doing, but it's a lot just from the world that we're living in that's asking us to make a lot of decisions every day that we've never had to make, like, is my mask in my purse before I walk out the door? And, you know, just a lot of micro decisions that we're making every day. And we're exhausted. Sitting in front of a Zoom meeting is not the same as being together. It does not provide us that same emotional fulfillment. And I just want to recognize that right out of the gate, that we are living in a tough time. And I think a lot of us are feeling the same. I came across this quote the other day. I'm a pretty heavy Twitter user. I use it to connect to friends and colleagues across the country. And this was posted by one of my surgeon friends. He says, medicine is the only profession where when the canary in the coal mine dies, leaders say, can't we just get more resilient canaries? And while he may be a surgeon, I think this really resonates with a lot of us who work in healthcare, kind of feeling sort of a nagging pressure that, you know, it's on us to just be more resilient and stronger. When really the work that we do, we don't have a lot of control over. So I want to explore that a little bit in the next hour with everyone. The concept of moral injury Started with the wartime, and a lot of the early data and descriptions of this is from the Veterans Affairs. And that's where I got this data straight from the Veterans Affairs. Moral injury is doing something that goes against your personal beliefs, which is called an active commission, doing something that I didn't want to do. And failing to do something in line with my personal beliefs is an active omission. I wanted to do something, but I was unable to. I was thwarted in my efforts to do what I wanted to do or felt was in line with my beliefs. So moral injury is that distressing psychological, behavioral, social, spiritual aftermath of exposure to such events that go across against my beliefs. And so this is where we get the idea of the conscientious objector in war, and the necessity of a soldier to end up killing someone else, even though it goes against their own, potentially goes against their own code of ethics. And this is where moral injury comes into play. And that's what it's described as. And this occurs in response to acting or witnessing behaviors that go against our beliefs. So not even just acting upon, but witnessing it all around us, which is really where the wartime experience informs what we currently describe as moral injury in healthcare. The hallmarks of this are feelings of guilt, shame, disgust, and anger. And I think in the moment, it's very difficult for someone who is experiencing moral injury to articulate those feelings. But over time, that's what really percolates to the surface. That those are the feelings that we get with moral injury. And struggling with the inability to forgive ourselves, just feeling extreme shame and self-persecution about the experience. And it has an impact on our spirituality. It is hard to reconcile the experience that we have in front of us with our deeply held faith. Moral injury is also described as distress experience when the decision maker is not the person who bears the burden of those decisions. And I got this quote from the surgical critical care, or actually critical care medicine bulletin that just came out, I believe it was yesterday or the day before. And I thought this was a great explanation of moral injury in the healthcare setting, is that we are beholden to a lot of decisions that are made at much higher levels. And then when we are at the bedside or in the office or counseling with a family or a patient, that the distress that we experience is sometimes because we are beholden to rules that we didn't make. So in healthcare, we have all kinds of crises that precipitate moral injury, such as natural disasters. This is an excellent book written about Hurricane Katrina. If you have an interest in reading such a book, this book called 5 Days at Memorial is about the aftermath of dealing with the flooded hospitals and the loss of power and resources in Hurricane Katrina, and just the devastating decisions that the physicians and nurses and staff had to make in the care and triaging of patients after Hurricane Katrina. It is extraordinarily distressing. Very well written book. Also humanitarian crises, and we've seen these all over the world: Venezuela, South Sudan, Rwanda. The crises that precipitate human crises, famine, anything that is just really, really difficult for us to understand how a government could hurt its people. And global pandemics, of course, which we're living in now. And this is a picture from the hospitals in New York City when they were just beyond capacity and having to discuss who gets ventilators when we run out of ventilators. Just really, really difficult conversations. Moral injury in healthcare workers more specifically has to do with resource allocation, deciding, like I mentioned, the ventilators, and deciding who gets healthcare. And how to carry out a plan that contradicts personal beliefs. So for example, in my job in critical care, sometimes I am faced with navigating the situation with a family of a patient who may have a devastating traumatic brain injury. And my moral code or ethics or beliefs, or what I would want for myself or my family, may be to pass peacefully and not live a life dependent on someone else. And when another family asks for care that I perceive to be futile, then that is the tension between trying to honor the autonomy of the patient and my integrity about utilizing resources for futility of care. And so those are very, very difficult situations. And I know many of you have been in those situations from different perspectives. And they're very, very distressing, hard situations. Also, witnessing discrimination in the workplace. I think we can't lose sight of the fact that this is moral injury when we see underrepresented minorities, when we see families, when we see patients who are discriminated against, whether based on race, gender, sexual orientation. This is hurtful to us from a moral and ethical standpoint, and it's hard for us to watch. Some of you may be familiar with this physician. His name is Zubania, and his kind of stage name is Z-Dog MD. And he has put out this video. That QR code there is to the video. And I will warn you that there's some foul language in it. So if you're interested in watching it, make sure the kiddos are out of the room. He kind of takes this concept a bit to an extreme. And so, you know, again, like I said, this may be a little bit of a controversial take on the term moral injury. But when taking a look at this concept of moral injury in healthcare workers, I think he brings up some really great points in this video. It's about 6 minutes long. And he says that it's not burnout, it's moral injury. That burnout really is kind of another way to say, maybe a little bit more sterilized word to say what we're experiencing actually is moral injury. So I think it's a really fascinating take on this from a healthcare worker's perspective. Moral injury has a lot of overlap with post-traumatic stress disorder, and the primary hallmarks that are overlapped is anger, depression, anxiety, potential substance abuse, insomnia, and nightmares. And then you can see the other descriptors that are more specific to either PTSD or moral injury, but I think it's very interesting that there is overlap. Compassion fatigue is the next thing I want to talk about. This is described by these 12 descriptors. It's the burden of seeing, we feel burdened by seeing the suffering of others, blaming others for their own suffering, feeling isolation or loss of pleasure. Again, the insomnia and nightmares, physical and mental fatigue, feelings of hopelessness or powerlessness, complaining about our work in life, overeating, excess use of drugs and alcohol, and denial of everything. I think when I looked at this list, I went, wow, a number of these things really resonate with me right now. You know, I feel physically and mentally fatigued, and I find myself snacking all the time because it's soothing to me. And so I think that there's a lot that we can recognize in ourselves in this list on compassion fatigue. So other names that have been used to describe compassion fatigue, and this comes from this paper from 2004, are vicarious traumatization, secondary traumatic stress reaction, empathic strain, burnout, and type 1 and 2 countertransference. And I just put these up here to say if you read in this space or in this literature, you're going to see all of these terms, which are pretty closely associated and maybe described somewhat differently, but I think you get the point that all of these things are sort of describing the same kind of constellation of issues. So what does it look like in the hospital? Well, many of you have been the one who's tried to fill out insurance claim forms and they get rejected. You know, a patient needs something, you know, they need a durable medical equipment, you know, they need a rehabilitation center, and it is denied. And that is moral injury when we are trying our best to do what we need to do for our patients and we can't get it. It's dealing with families who are difficult. It's dealing with families who are themselves dealing with trouble, and then engaging in a contentious conversation with a family about a care plan. It looks like taking care of an extraordinarily complicated, critically ill patient, and whether that's from a medical standpoint, from a chaplain standpoint, and supporting the family during a devastating time, as the social worker or case manager working on rehabilitation services. Every person who touches a very critically ill patient in some way, it's a burden. It's heavy to support a patient or a family through some of the worst times of their life. It looks like understanding how to care for a child potentially who's the victim of abuse, and just how upsetting it is to see that in real life and have to be to know the story. I've talked to some of my residents and students, of particularly in trauma. We say we can't unsee what we had to see. And so we have to process through some of the devastating complications or consequences of interpersonal violence. And it looks like telling a family member that their loved one has died. And it never gets easier. I've been doing this for 15 years, and I still get a knot in my stomach before I go into a room and need to talk to a family. And many of you have been there in some capacity as the support person for me as I come into that space to try to disclose to a family the loss of a loved one. It is exceedingly difficult, as many of you know. So how do we have an objective viewpoint of kind of how I'm doing, and like, am I really struggling? How do I even know? Well, it's hard to say, right? It's hard to know exactly how you kind of compare against benchmarks. But I think that this is a pretty good tool called the Professional Quality of Life Scale. And I've done this myself a couple of times, and that QR code will take you there. So you can kind of answer some questions and get sort of an objective viewpoint of, oh, maybe I'm processing a little better than I thought I was, or maybe I'm not processing well at all. And it can be just a good check-in for yourself about, you know, how you're doing, and maybe what resources would be helpful. So let's pivot a little bit to burnout. It was a little tough to find all of these statistics for various different groups, but I threw out a couple of the papers that I thought were some of the better ones to gather this data. And you can see, looking at that list there, that burnout runs anywhere from about 15 to 20%, all the way up to like 72% when, depending on the group that we're talking with. And now burnout, it depends on how you measure it, but that is to say, nearly everyone that is touching patients in our healthcare system has some degree of burnout. Specifically in the ICU, and I found this data to be very interesting, in the general population, 8 to 10% of people will develop clinically diagnosed PTSD. It's the 4th most common psychiatric diagnosis in our country. In the ICU staff, so nurses, physicians, and support staff in the ICU, 18 to 22% prevalence of PTSD, which is highly correlated with burnout, up to 80% burnout. The staff diagnosed with PTSD almost invariably experience burnout also. So extremely stressful situation in the ICU for any of you who have been in that setting. So what is burnout actually? Well, this is pretty well defined in the literature and has been described again and again. And the pretty well accepted definition of burnout is depersonalization, emotional exhaustion, and reduced personal accomplishment. So depersonalization is kind of feeling like you're sort of out of body, may not be the right term, but sort of detached from oneself. And you kind of look at the way you behave, the things you say or the things you do, and you go, that's so not typically me. That's out of character for me. And that is actually a marker of burnout. One of my favorite articles about burnout is use this quote to describe burnout, that it's the emotional manifestation of a profound mismatch between high expectations for one's future and the reality of daily life. And I think that just really encapsulates what many of us feel working in healthcare, that we have these lofty goals. Most of us went into our jobs saying that you know, we had a compassion and a heart for the work that we do. And then we're faced with the daily realities of administrative work, documentation, rules that we didn't make. And that leads us to burnout because we feel like we can't do the work that we had hoped to do when we started our careers. So the drivers of the burnout are all of the things that we've kind of talked about, dealing with adverse events. For many of us, it's a very heavy workload, long hours. The cognitive intensity of the work is really profound in some areas. Just having to make decision after decision after decision that are hard and heavy decisions. For most of us on this call, in some capacity, a lack of autonomy, like we talked about before. And to some degree, we are told how to function in our jobs and obey rules that we didn't create, or that we maybe even think are not good for us. Administrative burdens, like I mentioned, and fatigue and lack of quality sleep. And I think that is a huge, huge issue for many of us. I found this book, though, again, a little controversial. There's some pushback to Dr. Walker's writing, but I think he brings up some really great overarching points in this book that we have a lot of data to help us understand that sleep is important for our memory, both short and long-term memory. It is essential to smooth our mood, to improve our attention span, particularly attention to detail, mitigates depression and anxiety, and sleep is the driver of creativity. We cannot be creative problem solvers when we have lack of sleep. We need our REM sleep. We need all of our sleep cycles in order to nurture the part of our brain that allows us to be creative. And that's essential. And we're going to get to that in a couple of minutes. So as if we didn't experience all of these things before, I think many of us can look back at the last couple of years in our career and say, you know, yeah, I resonate with all of those things, not just now. And then the universe gave us COVID. And now we are navigating something that basically none of us have ever navigated before, is dealing with a global pandemic and all that comes with it, emotionally, personally, psychologically, politically. It's become just a very, very difficult burden for many of us on so many levels. But why? Why is this so hard? Why is this pandemic worse than Ebola? Why is this pandemic worse than dealing with the influenza every year? I mean, those diseases kill too. But COVID is unique in that it has a high lethality, but it's highly ambiguous. We know little about this disease right now, and its duration is long, and we don't quite have an end in sight. So this is a really busy slide, but I want to walk through this just a little bit with you about what happens, the psychological and behavioral responses to pandemics and disasters. So you'll see in each of those bubbles sort of our reactions. Health risk behaviors, distress reactions, psychiatric disorders, and then our own individual resilience. And all of these things overlap to frame our response to a pandemic or a disaster. What I want to point out to you in this slide is that some of these things are visible on the outside and some are not. And that's an important point I want to make to us as we work together, that sometimes it's easy to see someone else's irritability and anger, but what we don't see is that they're having trouble sleeping. Or it may be easy to see somebody's alcohol or tobacco misuse, but what we don't see is that deep inside they are depressed or anxious. And so I think this slide really drives home for me all of the pieces of our reactions, and some are visible and some are invisible. And I think that's why sometimes we have a hard time relating to one another, is there's a piece under the water that we don't see. Our risk factors for distress in a disaster such as this is things that were going on before, think about before COVID, our socioeconomic status, our family status, our social support network, our current underlying health. And then boom, COVID hits. And now we have this really, really difficult situation we're trying to navigate. We have an unknown duration and severity of our involvement with this disease. We have to bereave the loss of our careers as they were before. And in some cases, bereave the loss of friends and family that we've lost to this disease. And all of this leads, of course, to moral injury. And during the recovery phase, we're still going to have to deal with potentially job loss and financial hardships, ongoing fatigue, maybe loss of our social support system, and changes in our organizational support. So this is we are here for the long game with COVID. And this is one of my favorite slides recently to really kind of put into pictorial form sort of where we are. And I believe we're here. We're in disillusionment. We are still in this period where we're coming down off the high of the community cohesion. And I think a lot of us remember the banners and the signs and the frontline healthcare heroes and the pizzas that got delivered and all of the wonderful things. And as we know, that has kind of gone away. And that's fine, that's appropriate. We can't live there forever. But what happens then is we lose a little bit of that in it together feeling. And then we kind of hit down to rock bottom. So in this disillusionment phase, this is the exhaustion that we're feeling. Every man for himself kind of creeps in, like, I'm just trying to get by, sorry about you. Media interest fades, not because media isn't interested in talking about this, but instead of having a cohesive a national pride kind of a response, our media interest has turned to controversy and even to blame and finger pointing. And this is very distressful for many people. And this is the period of disaster response that requires the highest amount of emotional support. Overall in our country, the Gallup surveys, which Gallup is probably the premier survey organization in the world, their data tells us that about not quite 40% of adults feel less connected to friends and family, and 84% of us are avoiding gatherings. And I'm sure many of you can tell a story of birthday parties and weddings and anniversaries and family get-togethers that we're foregoing right now, especially those of us who have, older parents or immunocompromised friends or family. So we feel isolated. We really do. And it is stressful. This quote, I think, really sums up why we are struggling individually so much. Workplace performance may be the last domain affected under this stress, given the importance that our training places on patient care and professional responsibility. I think each of us carry with us the gravity of the responsibility that we were given in our jobs to always put the patient and family first, to always do what's right, no matter how many patients there are, no matter how many people there are to support, no matter how many hospital leaders need our support. We always have been taught, put the patient first. And that turns out to mean put ourselves last. And I think we don't articulate that and think that through, but that's really what we've been taught to do. And so we aren't going to let a patient die. We aren't going to let a family's go uncalled or unsupported. We're not just going to walk away from our work in the clinic or the hospital or in the classroom. We're going to keep giving and giving and giving until we have nothing left. So this is where we need to reach out to get our mental health support. And thankfully, it's taken this situation, but there have been a number of organizations that have come together to put out fairly strong statements about mental health support in healthcare workers and healthcare support staff. So the pandemic is an unprecedented modern public health crisis. The extent and nature of its lingering health effects on providers, whether or not they themselves have been infected, are not yet known. And the lingering effects on everyone who has to deal with the fallout from this disease, this is unknown. We don't know how this is going to turn out. So in order to minimize the loss of life from COVID-19 and its sequelae, and this is specifically referring to the loss of life in terms of suicide and from other future threats, to ensure patient access, it is vital that we work to preserve and protect the health of our medical workforce, specifically the mental health. And this statement was signed by dozens of high-powered organizations who signed this joint statement, sending out a strong message to our community and our lawmakers that we have to address this. Well, what are the barriers to accessing the mental health help that we actually could really benefit from? Well, there are a number, and I'm sure these will sound familiar to many of you, is time. I don't have time. I'm too busy. I don't have time to go see a therapist. Stigma. I'm afraid that if I disclose this on my medical licensing or credentialing applications that I'll be turned down or somehow penalized. Confidentiality. What if my boss finds out? Then will they think differently of me? Will that affect my ability to get a promotion? Will I be questioned about my work because I am seeing a therapist, or questioning its effectiveness? Like, I'm busy already. If I go talk to a therapist, how do I know it'll even help? How do I know that joining a group will even make a difference? And so these are real barriers to accessing the help we need. And sometimes the barrier is not knowing when to ask for help. So some of the hallmarks of needing help are when you feel completely overwhelmed, getting comments from others. And this was a big one for me about 6 years ago, a colleague of mine sat me down and said, "Jen, you are just not acting like yourself and you need to get some help." And at that time, I went to go talk to a counselor who really helped me realize I was burned out and I needed to make some changes in my personal life to get things back together. And I did, and it was extraordinarily helpful. It was life-changing, but it took a comment from a colleague to say, "Jen, you got to figure this out." And I'm forever grateful for that. At the point when we can say, "I feel like I'm depressed or anxious," that is a marker for getting help. And I think changing our mindset about getting help, it's actually preventative medicine. Seeking help from a therapist or a counselor or a psychiatrist or a group session or whatever the case may be is actually preventative medicine. Just like getting our colonoscopies and our mammograms, this is what we do to help us stay healthy in the future. Now, I have nothing against yoga. It is one of my activities of choice outside of running. But I do a little bit tongue in cheek say that if we could have yoga our way out of this, or MacGyvered our way out of all of this burnout and moral injury, we are a pretty smart crowd. And I think we would have done it by now. Like if there was some way that we could just magically make this all better, we would have done it. So enter wellness. I'm going to spend the next couple of minutes talking about something a little more positive. My job is wellness. And so I want to make the stark contrast between wellness and all the things we've just been talking about. When I first took my job about a year ago, I did a ton of reading, and all of the literature that I read was a little hazy on what the definition of wellness is. So I did find this systematic review, and I thought it was very fascinating. This paper suggested that of all the papers that have been written up with about quote wellness, only about 15% of them actually defined wellness. So the first thing I set out to do was to say, when I use that word, I want us all to be on the same page. Like, what am I talking about? And so the definition that I am using in my role is a sense of vitality or thriving, a sense of purpose and meaningfulness and calling. There's an ancient Athenian word called eudaimonia, which is this concept of an overall well spirit. And this crosses multiple domains. And most importantly, it is a continuous process. We never just wake up one day and all of a sudden we're well. That is not what wellness is. There is no finish line to wellness. We are continually working on personal and team and organizational growth. And so I hope you can see with those definitions that there is a giant space between wellness and burnout. So just having a lack of burnout is not the same as achieving wellness. There's a giant gray space in between. And I think that's where most of us live most of the time. And we're constantly striving to help ourselves and our groups achieve healthier wellness state. But there's a big space above burnout. So at IU, this is the model that I think of that will promote wellness. And it's the working together, the three pieces of personal growth, team collaboration, and a system culture. So one of the things that I really feel passionate about is that wellness is not just the responsibility of the individual. And the concept of here's some resources, here's a couple apps and some yoga and, take a couple minutes for, a walk around the block and you'll feel better and check the box, there's wellness, is very misguided. That wellness is really about taking charge of my own personal growth and making sure that I'm making healthy choices, but also functioning in a healthy team and being supported by a healthy system. Dr. Martin Seligman is who runs the Positive Psychology Center at the University of Pennsylvania, says that of all the positive strengths we've looked at, people who are the highest in gratitude are also the highest in well-being. That is powerful, and gratitude is a choice. Gratitude is not a happenstance, it is a choice, and it is highly correlated with overall well-being. Author Angela Duckworth says in her book, Grit, even at the top of the grit scale, grit went hand in hand with well-being no matter how I measured it. So again, kind of having that mentality that grit is in it for the long haul, sticking it out, having stamina, that is related to well-being. Foundational to a healthy team is psychological safety. And psychological safety is a concept that protects our space for moderate risk-taking. It's the way that our team is designed to promote people speaking their mind in a safe place, that you won't be punished for having a disparate view. And that promotes creativity and increases humor, appreciates divergent thinking, allows people to challenge but not feel threatened, embraces conflict, replaces blame with curiosity, and uses trust as the default position. And this is just so foundational for me. The day I got married, my dad took my hand and my husband's hand and he put our hands together and he said, always assume that the other person has your best interest at heart. And I thought that was just some really great marriage advice, but it turns out it's a pretty darn good life advice. Just assuming that the other person is not out to get me, assuming that trust is the default position is a great way to go about my relationships. Now, sometimes that it will not be the truth, that that person didn't have my best intentions at heart, but starting with they actually want the best for me is a great place to start. We also know that leadership matters when it comes to wellness. So for those of us in the room who have leadership roles, no matter what they are, a small team, a big team, an entire organization, for each point increase in a composite leadership score, there is a 3.3% decrease in the likelihood of burnout for those that we lead. So effective, healthy, collaborative leadership is associated with a decreased likelihood of burnout for those that we lead. Although burnout is a system issue, most institutions operate under the erroneous framework that burnout and professional satisfaction are solely the responsibility of the individual physician or staff member. Engagement is the positive antithesis of burnout and is characterized by vigor, dedication, and absorption in one's work. That is to say, not being distracted or diverted away from unimportant work. Something that maybe a lot of you in this room, in fact, I know a lot of you in this talk are familiar with, is something called psychological first aid. And the QR code there takes you to the World Health Organization's model. It's a really great download book that I think is really fantastic. A number of you are trained in psychological first aid, know much about it, can probably tell me more about it than I can tell you. But the basic fundamentals of psychological first aid are, how do we support one another? This is that team aspect. How do we respond to one another in this crisis, whether it's COVID or the next crisis that we face together? And there's some very good pearls about how do you respond to someone, asking, are you okay? How can I support you? And not providing platitudes like, everything will be fine, it's okay, or just calm down. That those things can actually be harmful. So if you're interested in reading more about psychological first aid, that publication by the World Health Organization, I think, is a really great resource. Now, what are we going to do about it? So every time I give a talk like this, it's really easy to talk about all the problems, and it's really hard to come up with all the solutions. But this is a book I read pretty recently, I think is a very powerful book that is called Upstream. And the whole point of the book is fix the problem before it becomes a problem. And so the question I have to this group is, what are the things that we can move on upstream to fix the problems that we feel downstream? And we may feel helpless in this endeavor, but it's been really great for me to start thinking about these things, about what work needs to happen upstream to change the way I feel downstream and the way that I work. And so this is a challenge I'm putting to myself and to those that I work with about reframing the way that we think about things and how we can fix them before they become a problem. So these are the questions the author asks in the book, and I'll leave you to read them. But I think these are really interesting questions about problem solving. So just think about all of the people who've been at the hands of suffering and have been empowered to fix the problems. Now, I'm not saying that it's our job to all go out and fix all the problems ourselves. This has to be a synergistic effort, individually, as a team, and with other systems and at the organizational level. But think about all that's been done in our country over the decades. We actually have the best solutions to our own problems. Advocacy is very hard work, but it's also effective and very rewarding work. So when we see the issues, when we see the things that are leading to our moral distress, we do have a responsibility to codify those issues and to speak up and say, these are the things that are causing our trouble. Well, where are we now? Remember, I said, I think we're here, but look where we're headed. We're headed to reconstruction. There is hope. So in the last couple of slides, I want to leave you is that we are going to get to the reconstruction phase. We will have recovery and rebuilding. We will continue to grieve losses, but we will return to some more normal feelings. We will return to some stability. This is a super busy slide. These slides will be available to all of you afterwards, so I'm not going to go through this in detail. But all of this is to say that there is a lot of literature that points to post-traumatic growth, which means when we go through a very difficult time, most of us will actually experience growth. We become stronger, not weaker, and across multiple domains. This is my most recent reading list. I think diving into a good book can be very empowering. I've learned a lot, gained a lot of ideas, and have really shaped my my work by reading the works of other people. And so I would encourage you to do the same. Some of my greatest advice recently has been to give yourself some grace. Give yourself some grace about some deadlines. Give yourself some grace about a project you had hoped to get to but can't get to, about a phone call that you meant to make and it slipped your mind. Like, just give yourself some grace. You are doing the best that you can. I just finished this book the other day. While this is a book written to women in midlife, I think this quote is really fantastic and applies to all of us. One of the biggest midlife problems I had to confront was anxiety paired with an abiding belief that I should not be anxious. Well, that's unreasonable. It would be weird, frankly, if I weren't anxious. Human beings are wired to see situations as being unfair to us. Oddly, knowing that I have every reason in the world to be freaking out has made me much more relaxed. I think that was very apropos for our time. Now is the time to lean down and help one another. This is a great concept that I've stolen from a friend who brought this from improvisational theater. She says in improv theater, one of the main principles is when you go out on stage, your goal is to make the other person look good. The joke goes over, the scene works when each person is trying to make the other person look good, not when they're trying to make themselves look good. And I just think this is a fantastic analogy for how we can empower and support one another in our work in the clinical space and in education and all of the work that we do. And when our mindset is, I'm here to make you look good, it makes everyone look good. So dive in with the people that you work with. This is a picture of me. I wandered down to the basement of Methodist Hospital one day and met all the folks who are the transport team. So these are the folks who move the patients all about the hospital. I hung out with them for a little while and we had a great time. And it was really cool to learn about the work of another group. These are my residents in the ICU the other week, taking a break. We were extraordinarily busy in the ICU, really on our feet for about 6-7 hours at a time. And so we did a little impromptu shoulder massage train. Finding these little moments of joy, even in the midst of struggle, is just really, really enlightening. If you haven't been paying attention for the last 45 minutes, now's the time to look away from the Twitter thread for a minute. This is the only slide I really want you to remember. Invest in relationships. Relationships will always be what matters. Relationships will always be what brings us through these really, really hard times. This is always what matters. It's always about the people. This is what my friend told me yesterday. He said, this crap is hard and you are doing a great job. This place, these patients need you, but not more than your family, and you need you. He said, I appreciate you, but never as much as your family will. And I just thought he said that so well. And found that just really, really encouraging, that we're all living in a hard space right now, but you are doing a great job. This place needs you, your patients and your colleagues need you, but not more than your family, and you need you. And this is my family, and this is why I do what I do. This is important to me. The work that I do, I find passionate and rewarding, but at the end of the day, these are my favorite humans that I come home to. And this is why I do what I do. And with that, I will stop, and I am very happy to take any questions.
Okay, well, we have a variety of them. So first of all, thank you. Thank you for that talk. I think I would like to start off that Tony mentions that she's a social worker, and she just wanted to say, I didn't even have the words for how helpful this is and how much I didn't know I needed this talk. So thank you. Okay, so first question is, can you talk a little bit more about moral distress versus moral injury?
So that's a kind of a finer point. And I will tell you, I do not have a dissertation in that body of work. So I'm going to defer that very fine point between moral injury and moral distress. I think moral injury is sort of a term that we would use to say it's a more severe form of distress. But that's a great question that, I think that it's sort of a continuum of the injury being more distressful than distress itself.
Thank you. Can you speak a little bit about the difference between compassion fatigue and moral injury in the setting of public safety officers?
Interesting. So I think that's a great question. So the first thing that comes to mind is, I think moral injury, by definition, moral injury is seeing something or experiencing something that threatens your actual beliefs or value system. Compassion fatigue more has to do with not having your belief system or values threatened, but experiencing over and over again, just tough situations, like seeing sad situations, having to intervene in maybe family situations, or protecting safety, even from like a natural disaster or natural causes that are it's just fatiguing to be in difficult situations. So the moral injury really has to do with a threat to beliefs and values, and compassion fatigue really has to do with just the fatigue of seeing hard things over and over again that don't necessarily violate beliefs and values.
We are getting a lot of requests for the slides, and Dr. Hartwell has already agreed to share those. And so we are going to ask those of you who would like the slides, if you could email that request to fcme.org. We will get those to, or I'm so sorry, fcme@iuhealth.org. I'm so sorry, fcme@iuhealth.org. We will get those to you. We're not going to send them out to everybody, but if you want them, just please, please, please let us know. She has already agreed to let us have them. Can you talk a little bit more, Dr. Hartwell, about what your thoughts are about differentiating grit from workaholism?
Yeah, great question. So grit really has to do with kind of the long-term tenacity, commitment, and hard work, but not overwork. So grit would have one believe that hard work also has boundaries, and because grit is the understanding that in order to do this work again tomorrow, I have to preserve myself in order to do the work again tomorrow. So grit is kind of this concept of not being afraid of setbacks. It's being able to pick yourself up off the ground when something doesn't go your way. Workaholism is, or overwork is, failing to recognize those boundaries and actually having a very short-term perspective, just working to try to get through what you can for the day, recognizing that maybe the better part of valor is stopping. So grit is the long game, and I think overwork is actually the short game.
All right. Do you feel like medical students and residents undergo a tremendous amount of moral injury? And how do you feel this impacts them as they enter the medical field as physicians?
Oh, that's a heavy one. So sadly, my answer is yes. Students and residents absolutely face moral injury and burnout. We have data to prove that. And we have stories to prove that. We have stories that medical students come in bright-eyed and thrilled and excited and passionate. And as I sadly sometimes comment, and I say, well, don't worry, they'll be broken by the time they're a resident. It's grueling, and the system that we grow up in nurtures us in an unhealthy way to lose some of that that spark and that passion. And so I will say that, you know, one of my jobs and one of the things I feel strongly about is engaging with our learners early on, and not only engaging with early medical students and early residents, but also changing the system. I was taught that if I didn't work 100 hours a week, that I was doing it wrong and that I was less committed to my patients at the cost to my family. And so we have to change that narrative in medicine. And we have to change it in nursing and in medical students and in all of our support staff, our chaplains, our social workers, our case managers, our, you know, everybody in healthcare needs to hear, we have to take care of each other before we're going to take care of our patients. And so that culture change has to happen. And that is heavy on my heart, because yes, I'm seeing the medical students and residents just get crushed before they even get started.
Another question, how would you recommend practicing gratitude in the workplace to combat burnout and promote well-being?
Okay, this is a great one. So I will give you an example of what I've done with my team. Is every day before COVID, now we do it over a Zoom call, but we had a whiteboard with all the list of things we had to do to talk about in turnover. So what patients did we admit today, who needs surgery, who needs a follow-up, all the things we need to talk about. And at the end of that list, I just wrote on the board 3 good things. And that meant before we could leave for the day, we all had each team, the trauma team, the ICU team, and the acute care, or the EGS team, the emergency general surgery team, each team had to say 1 good thing, so that by the time we left, the last words out of our mouth were 3 good things that happened that day. And it was just, it was awesome. Like sometimes it would be a medical student that says, I got to throw my first stitch today. Sometimes it was, a resident who said, Mr. So-and-so who we thought was going to die, we discharged today. So intentional gratitude, on an individual level, a gratitude journal. I journal every morning and I try to put something I'm thankful for on the page before I leave. So it can look however you want it, a jar that people put positive things in, any way you want, but I would say it has to be intentional.
Thank you. There is some research that people who do emotional labor have issues with compassion fatigue, secondary trauma, while burnout can happen to any worker on the job. There's a question there. I just didn't know if you wanted to comment about that.
Yeah. So the thing about compassion fatigue is very interesting. And again, like I said, there's some controversy around it. Is some people say there's not actually compassion fatigue, but compassion actually helps us thrive in our job. So I think that these are very actually complex issues, complex and interplayed issues. I think compassion fatigue really actually comes down to needing the coping skills in order to be able to have a healthy balance between being compassionate and drawing boundaries around protecting our own selves. Burnout, I think, is a little bit more driven by, some of the other outside drivers like workload and administrative burdens and not having the autonomy to do things that we want to do. So I think that they're a little different in that way. But yeah, I think compassion fatigue, it is driven by dealing with a lot of difficult situations. Yeah, I think that there's also a silver lining that sometimes compassion is exactly what we need to help mitigate burnout.
Here's another bit more of a statement than a question, but I'm sure you can comment. It says, it seems as if a person experiences moral injury and distress, the company sees the employee's reaction as a threat to the welfare of the company, and the employee is released.
Mm-hmm. Sadly, yes. And this is a complex issue, and you're exactly right. And this comes down to, where I talked a little bit about shame and fear, about reaching out for help, because our natural responses sometimes are looked at as a threat to the company, and you're not towing the party line, and patient satisfaction isn't going to be happy, isn't going to be good, and your difficulties are a threat to us, so we'll just let you go. Now, I do think that IU Health is trying to do a better job. No organization is perfect, and I can say that as having worked in a couple different organizations, but I think you're right. I think we have a national problem. I think we have a national healthcare problem. That has been our narrative for a long time, is that the bottom line is money and patient satisfaction instead of the primary goal being taking care of those who are taking care of our patients.
I think this might end up being the last question. And I will say that Dr. Hartwell, there are so many positive comments on here. We'll leave them so that you can read them yourself, because we don't want you to miss those great comments that people have said. Thank you.
Great, thanks.
But the last one, I think, looking at the time, is having a more balanced life often results in fewer work hours and less work being done overall. How can decision makers within organizations balance the cost of burnout with the expected workload?
Yeah, so this is the $1 million question. So I'll offer just a couple of things. One, I do think we have to rethink as a country how we provide healthcare. I think we need to reset our expectations a little bit. I do think that it's going to require rethinking how we fund healthcare, how we fund healthcare education, how we fund how insurance companies pay. And I think it's going to require some of us to have changes in expectations about income, because we can't have it all. We can't work fewer hours and make the same amount of money. That's mathematically not possible. And that statement doesn't apply to everyone, but I think that it's something we have to bear in mind about level setting expectations. I also think that we do have current data that tells us that when people leave an organization due to burnout, the cost of replacing a physician or a advanced practice provider or a nurse is very expensive. It's very expensive to recruit and train someone to replace a highly trained employee. And so mitigating burnout and preventing turnover is actually cost effective. And so I think we just need to do the math to help figure out, like, when we invest in things that mitigate burnout and let people dial back just a little bit, there's a return on investment of that, actually, and that organizations can actually save money by not having to retrain people to replace those who've left due to burnout. So I think that again, it's a fantastic question. It's the $1 million question. I think there's a lot of angles to look at it from. And if you have any brilliant ideas, please shoot me an email. It's kind of my life's work.
Dr. Hartwell, thank you. Before we let people go, I just want to remind anybody that that signed up, you will be receiving your information tomorrow for CE and CME. And if you would like to get the slides, to please email fcme@iuhealth.org. Dr. Hartwell, we are so very grateful for your just taking this time to give us all a breath of fresh air, for giving us permission to be struggling right now, and for then also giving us ideas about how we can reach that hope. And thanks for giving us hope. So thanks, everybody. We will see you all in a month. Bye-bye.
Thank you.